Tonight, guys, as you know, we always try to feature as many voices from around the table on the Chronic Pain Club talk show as we can, both patient, key opinion leaders, medical professionals, etc. And tonight is no different, as I'm delighted to welcome onto the show Wes Michael from the United States, who's the founder and president of Rare Patient Voice. Wes, thank you so much for joining me.
Oh, great to be here. Yeah, hello from Baltimore, Maryland, in the U.S. So.
Brilliant. Oh, thank you for joining us on your Sunday afternoon. Before we talk about Rare Patient Voice, do you want to maybe just set the scene and let us know a little bit about yourself, who you are, what you do, and then we'll go from there?
Yeah, so I started this company 11 years ago, but I was a market researcher by training, getting into people's heads, why they think what they think and what they do about that, et cetera, et cetera. And I've come a long way with that. And then, so we'll get into that. And we like to do that now in health-related topics. I'm looking out a window. I see a dog. I have two kids that are grown. One of them has a dog that comes over here. We babysit the dog in addition to our own dog. And we're raising our 5-year-old grandson, who's terrific. Terrific fun for me, kind of going through things a second time,
Yeah, I've got a 5-year-old at the moment, so I know how
energetic parallel lives there.
To be able to hand them back must be lovely. You get the best of both worlds.
Yeah.
Well, thank you so much for letting us know. And then that's always nice to know a bit about the person around the work. So obviously you're joining us as the founder and the president of Rare Patient Voice. And it is an organisation I've seen a lot on my socials, particularly since the pandemic. But for anyone who's maybe not aware of who you guys are and what you do you want to maybe give us a bit of set the scene a little bit?
Yeah, it's kind of a simple proposition. We have folks that join us, meaning we have their confidential information. We don't share it. We don't send it to anybody. But we know your name. Most importantly, we know your email, because we're not calling. Mm-hmm. Anyway, we have your email and what conditions you may have. We get requests all the time from companies that want to interview. Usually they're companies that are coming out with a treatment or a device, or it could be academic, but they're looking for people with lupus or rheumatoid arthritis or any of a number of hundreds of diseases and conditions. And so we're the matchmaker. We'll invite people to share their experiences if they're interested in doing that, and they get compensated for it. So it's kind of a win-win. People love to get their voice heard. They need to know what I think. If they're developing a treatment or procedure, whatever it is, the companies realize they have to. It was a big breakthrough for them to realize, let's talk to the people that we're going to be using our product. It's sounds pretty obvious, but it took a long time, I think, for people to get their companies to get there, and people so much want to share that. And our thing is, we compensate, I should say, and we're for profit, so we charge them too, but they're happy to pay us a little bit, and then of course we pay patients and their caregivers. So there's nobody losing in this thing, as far as I can tell. Nobody has to do anything, and the companies are so happy to be able to get people and get them fairly rapidly that are excited to talk about their opinions and experiences.
Yeah, and like, as somebody who's been in this sort of advocacy game a while now, probably longer than is maybe healthy for me, it wasn't always like that, Like, I know it was either you weren't included, or if you were, it was expected to be in like a voluntary capacity. We weren't seen as sort of like experts in our conditions and our experiences and that sort of thing. So from my point of view, it's a really important change of direction,
Definitely. I mean, obviously, physicians are very important, but it used to be seen as, well, they're prescribing and people just do what the physician says, so they're the people we need to talk to. Well, that's important, and I get it, but no, people are empowered now, and they learn about their conditions, and they go online, and both of them are very important. But it's like, who are the physicians there for? For the patients. So it all comes back to the patients and the caregivers, children, and that whole community. Again, it sounds so obvious now, but sometimes it takes a while for things to
get
that way.
And I still don't think it's the norm just yet. I still get my fair share of requests and things like that.
Some of it is, I worry some of it is lip service. The biggest word you hear out there now is patient centricity, putting the patient at the center, which is what, and I think some companies are now really doing it. Others are talking about it, which is a good first step, I guess,
Yeah.
But it'll just be lip service, and then they come after the fact, and after they've already made their decisions, and well, then you can't have any input then.
And unfortunately, that was my early experience, that sort of tokenism, tick box, and whatever you want to call it, where it's kind of like, oh, well, we included the patient, but yeah, did you include the patient at a stage where they could have actually changed anything or shaped it? Or the other one that I always find, I don't know what your experience of this is like, when I'll do a focus group or something, one of the first things I ask is, well, who decided this was a need? Where did the need come from? Because I'm so used to being brought in at the end over, this is historical, not so much now,
Yeah.
where it was like, well, who decided this is what the patient wanted? Because if it wasn't the patient in that conversation as well, then maybe we need to wind it back a little bit,
Exactly. It's easy. I always say you get all these, I'm sure they're very smart people with their master's degrees, but they're not the patient, or even the wonderful patient advocates. Some of them are so good, but they're not what I call the run of the mill patient. And they're both
Yeah.
very important, but don't talk to somebody that can read a journal article and understand it.
Yeah.
That's not the normal person. You gotta include everybody.
Exactly. That's exactly where this whole show was born, because I realized there was only so many times I could tell my story, and it was one story, and that didn't feel like a representation of the community to me. So we thought we'd get people on and share lots of stories, and therefore we can then get a bit more of a community consensus. So you have no idea how well suited to this show your role is, your organization, everything. So if we could wind that back,
sure.
Tell us about how it started. Obviously, it sounds like you had a bit of a background in market and things already. But what made you sort of see the need there?
I actually started being a market researcher in food products like Cheerios, cereal, and spices and things like that. Then I got involved in the healthcare area, and because I had this consumer background. So again, it was when companies were just starting to say, we need to listen to the patient. And a company came to where I was working. A company came to us in the hemophilia space.
Okay.
And this is time in the late 90s. A whole generation of people with hemophilia had been wiped out because the blood products they were given had HIV. People didn't understand what was going on, and it's just tragic. But anyway, they had a product, and they said, "Can you create what we call a panel research? A lot of patients and caregivers, because we want to learn from them what we can do, what services we can. Because it wasn't just about here's your factor, take it every other day. It was what services can we provide from a marketing point of view. They want to make people loyal to them. Well, that's a good thing if they want to do things that people do want to see. So they say, can you build us a panel of that? So we went in the U.S. At that point, they were just looking at U.S. and we went to what at the time was the National Hemophilia Foundation conference. And people from around the country, you can imagine parents with their kids, they all come around, and we said, hey, would you like to join with us? And from time to time, we'll invite you to a survey and interview. And it was very successful. We had folks sign up and do that. But what gave me the idea to create Rare Patient Voice was about 2 years later, I was at that same conference, because every year we'd go back, because they move it around different cities, and we want to recruit people in every place we could. Somebody from a different pharmaceutical company came up to me and said, I hear you have this hemophilia panel. Can we access it? Well, the answer is no. I mean, if client A pays for something, client B, we can't have it. But I still remember that moment. I'm like, no, you can't. But they gave me why not create a panel that's not beholden? It's not just for one study, not just for one client, but people can share across categories, diseases, clients. And I had that idea for many years. And I remember telling my wife about it. And I don't know if she probably was laughing at me. But I had that, and over the years, I kept thinking, I think there's a need, because more and more companies wanted to talk to patients and caregivers, and it wasn't easy to find them, especially with rare conditions. But in general, it's not like, we have people. Obviously, we have people that drive Chevys and people that No, it's like, well, how do we find people with these conditions? So I had that idea, and then in 2013, actually, everything came together for me. It didn't look positive at the time. I had to be pushed into it. I was with a company that ran short on money and offered to let me work without being paid for a while.
Okay.
And my wife had been out of the workforce raising her kids, and they were like 11 or 12 at the time, and she was looking for a job. And here in the US at that time, it was all about the healthcare. It's like, wait a minute, if I'm not working, we want to be the kids and the family to be protected. So she landed a local job, actually with the Kidney Foundation locally here. So she was working there, and I said, okay, this is perfect timing. I'm going to start this thing that I've always talked about and thought about. And we're going to go. And the first thing I did was go back to a hemophilia event. Because I had done it before, and I'd been involved in that. And I knew there was a lot of interest. And to this day, there's been, it's one of those categories of conditions where there's been a lot of new things over time. They've really made a lot of improvements for folks. But anyway, so when that happens, companies have a lot of need. They want to talk to people and see how it affects them. So that was the first thing I did. I went to the hemophilia conference under the new name, Rare Patient Voice, with our clipboards and our giveaway items, and talked to people and signed them up. And that was our first thing. So it went from me being the one guy with the one disease. Now we have like 1,500 conditions covered.
Mm-hmm.
Some we might have 5 people, some we have 5,000, but all over the map. We have a wonderful team of 40 some folks. We've paid patients in U.S. dollars. Pardon me for the British folks, but for U.S. dollars, we paid them over $13 million, and we've done 10,000 studies. So thank God it's not just me. It's a wonderful team. And one of the things I didn't plan at all. It's the most wonderful thing to me that happened is, as we grew, we found the people we would hire would be the people we would meet at these events, at the conferences and at the walks. And somehow people would indicate, hey, what can I do for you? I'm looking. And they would start working part-time for us. If they were in Chicago, they're like, oh, instead of me flying to Chicago, you're in Chicago. Here's the tablecloth and the clipboards and the training. And who better than a patient saying, I do this.
I love that.
And I said, oh, that's. So they started working for us part-time. Then as we would go, we would say, hey, we need a full-time project manager. And then some of the folks would say, hey, do you have anything full-time? And we, it's a two-way street. Yeah. They wanted more. They got to know us. We knew them and said, boy, they have a lot on the ball. Let's ask that. So we've grown by promoting folks like that to full-time positions. So much of our staff now is from the disease community, and who better to deal with patients? They get it. They go, I know, I have MS, we have flare. They're not just treating people like numbers on a page. They know the patients. And then on the other hand, they deal with the clients that want this, and they can explain, no, because if you're in an interview, things can happen. The interview is not as important as if your kid is having a flare and you're going to the hospital, whatever it might be. Yeah. And so they can explain it, and the clients understand, but intellectually, they have to be told that, hey, this is obviously they're going to, don't worry, we'll reschedule these people. Everybody's very responsive. So it's really, again, I didn't plan it, but it couldn't have worked out any better to get folks that way. So
I love that, and we talk a lot about, where it comes up a lot on this show when we have lived experience on here, is around that sort of like patient priorities and pain points, and anyone that's done a focus group or an ad board or something like that, like I have, will know that a lot of those priorities are assumed, and then you have to quickly sort of say, well, actually, what matters to me more than what hurts or where it hurts and everything else. So I think that's where it's really important about that patient involvement, because you can't replicate that. You can't replicate understanding, so with my condition, I've got a type of arthritis. Everybody assumes pain is the priority. And I've got a 5-year-old. It's not. My mobility is more of a priority. My amount of sleep that I'm getting is more of a priority. So I think it's that stuff you can't capture unless it's coming from the patient.
You remind me, I was at I think it was a pulmonary fibrosis group, and it was a wonderful conference because it was patients, but also researchers and physicians, all in the same conference. And the researchers got up there and said, we're working on these new treatments and we're going to save your life. And the patients just said, that is terrific, but can you help my cough? And they're saying, but the cough isn't what's killing you. I know, but I don't want to live if I have to keep this cough. So they learn what's the priority for the patient, because you think, obviously, well, push everything aside. We want to keep them alive. They're like, no, quality of life is important too. And and it was great to see the meeting of the minds. They need to hear that, because don't assume, right? You're likely to be wrong.
Yeah, but it's like mental health's another one. It always comes up. Well, nobody never mentions it. It was because nobody's equipped to ask it. So obviously, the data you're getting is sort of skewed, because if the conversation isn't shaped and has that question in it, then it's not being offered, and therefore you don't get the answers to tell you how much of that's a priority. But anyway, I go off on a tangent. But I now understand from that story, and thank you for sharing that now, why it's Rare Patient Voice, because of because I understand you don't cover just rare diseases now,
right?
And obviously, because of the origin story there with the haemophilia and everything, I suppose that's where it came from.
Yeah, I just assumed nobody would be asking us for non-rare, because there's big research panels. As I say, you can get people that eat certain foods or drive certain cars, and you would find people with, say, diabetes, right, or something like that, because unfortunately the prevalence is high enough. So I just assumed nobody would be coming to us for that. Well, two things. Again, in retrospect, it's these things look so obvious. Two things. People don't have just one condition,
Yeah,
right? These things,
unfortunately. Yeah.
especially autoimmune, they travel together. So somebody would say, for example, okay, I like to sign up. I have hemophilia. Hey, I have asthma too. Do you want me to list that? I'm like, uh, or my friend here, can he sign up? He has high blood pressure. And I was like, you hate to be restrictive and not let people.
Yeah, yeah,
Well, and at the time, we were giving everybody who signed up a gift card. Now we've switched it a little bit for people that refer, and then we pay when you do the studies. But so I was worried about paying all these people that we. But then, guess what? As soon as I said, "Let me think about it," clients would call and say, "Do you have people with asthma? Do you have people with diabetes?" I say, "Okay, great. I'm not saying no to anybody. That makes it easy. We'll invite people with any and all conditions." And I said, but I don't want to change the name. We kind of established, and even if you're not technically a rare, the U.S. has certain definitions in the U.K. and there's certain definitions, and it's like, even if you're not technically rare, everybody's rare in their own way. They're hard to find. So, and I like the idea of focusing on the rare. So we added a tagline, and we say also non-rare. Well, rare and non-rare, that pretty much covers the waterfront. I like to say a lot of again, when we do work across all these, but so many of them are in the category I call medium rare. And like MS or lupus or things, they're not run of the mill, but technically some of those, at least in the US, are not defined as rare. But they're harder to find. And the good news is there's lots of work being done. I love it when we get a request, because nobody's doing it for fun. They're not paying to do a survey. They're doing it because they're working on some kind of a new treatment, a new device, something. And I don't know if it's going to be, this good or really good, but at least it's a step in the right direction.
And also, I find it helps like massively with like things like the comorbidity side, because with the condition I have, there's lots of comorbidities associated with, but people didn't really acknowledge it or associate it. But then suddenly, when you can see that all these people are signing up with psoriatic arthritis, for example, and they're all saying they've got cardiovascular issues and things like that, then suddenly the where to focus the efforts becomes a lot clearer, doesn't it?
Oh, yeah, it is amazing too, because again, so many people would sign up. I remember I was at Sjogren's syndrome. If you remember, I was at an event they had, and a young woman came up. If you just looked at her, you say, "Well, obviously she doesn't have any condition." We have a little sheet there with some lines on it, name, email. She says, "Can I write on the back?" She had so many, parallel conditions that went along with it. And it's like, oh my goodness. And then as a lot of your listeners probably realize, one of the problems with clinical trials is they often want that pure patient. And I get from a scientific viewpoint, right? They don't want all these extraneous factors, but that's not the real patient. The real patient has these other things. I don't know how to answer that. I'm not the scientist setting it up, but please realize that you may be asking for somebody that doesn't exist, or they're so different that that's not really who you should be testing.
Yeah. And I think as well on the patient voice pain point thing, which while we're on that subject, I think is I done one recently where it came up about children with a condition and how they were going to compensate the parents, and it was like just a financial thing, and I was sort of having that conversation with them and trying to explain, well, it might not be just a financial thing because they're already taking lots of time off work to attend routine appointments and tests and everything else, and if that study is then the extra however many days a year absence from work that is the difference between them maintaining their job and losing their jobs, and there's a whole bigger picture to consider. So I think that's where like the role that people like yourself and maybe the bits I do as well, where we can help them understand that bigger picture of like the impact, the burden, the wider burden of the disease.
We sometimes we're fortunate we do a study ourselves, because when our clients do it, we really don't see the answers. We're not listening in. We don't see the surveys. And if you're a pharmaceutical company, it's top secret. You're not seeing it. But we often do our own that we'll present at a conference or a webinar and such. And that's so exciting, because we did one recently on kind of what we were just relating to, the burden on the caregiver. How does it affect the caregiver? And the caregivers could be caregivers of kids with a disease, or caregivers of dementia parents, or a spouse. It's all over the map. It was so incredible because one is they're doing so many tasks. You think caregiver, no, there's dozens of tasks, and within each category there's dozens of items. There's so much that they're doing to help. And then the key thing was, And then we ask them, of course, about clinical trials or doing these things. And they have a life they're trying to live. They
Mhm.
may have one kid with this disease, but they have two other kids that don't. They've got to balance all that. If they need to fly to another city for a trial, do they bring the family? Is it every month? I mean, and they have their own jobs. And so many people have, and it's often the mom, if you will, who
Yeah.
stops a wonderful career to be a 24/7 caregiver. And the people that are taking different jobs than they would be qualified for because of the needs to take care of the patient. It was but yeah, financially, emotionally, and then on top of all this, right? A lot of people have mental health issues because this is not easy stuff.
Yeah. Yeah.
So it's kind of overwhelming to see it all. But we see all that, and it's like, here's the burden, and how can we help? Some of it is how. One of the key things people would mention would be, can I just get a break? But not with somebody that knows what they're doing. They
Yeah.
have to understand this condition. They need X. Don't just assume, oh, they're okay. I'll take them for a while. You know how people mean well, but
Yes.
they look fine. We'll just play football. No, they can't do that. Nobody can be on 24/7.
No.
So anyway,
And so
it's
few people are asking as well, which is why I was absolutely loved when I saw your website, and even on the information you guys offered on the sign up process, the fact that you're mentioning caregivers constantly, because it is something we bang on this show a lot about, and regular listeners are going to get tired of hearing me say that, who's asking the caregivers if they're okay, because if they, fall down, then, say, for example, if my wife struggles, then I struggle, because she's a big part in keeping me well and making sure I can turn up and do this sort of thing on a Sunday night. And so the fact that that is so prominent in your thinking, I think is a huge positive. So thank you on behalf of us all for
and
that.
it's what makes it even more complicated is a lot of the caregivers are also patients of might be a completely
Yeah.
different condition. Say you're a caregiver of three other people. It's two kids or a spouse and then you have a couple of conditions. There's so much going on there. It's again, in fact, it can be overwhelming, and that can trigger other issues, because it's hard to manage all this. And no credit to us males, but so much of it falls on females. This
Yeah.
caregiving role.
Yeah, that's true.
It's just I don't know, tradition for all the various reasons, and it just just to hear them talk and explain to us and do that, it's like, there's got to be a better way to handle all this. I don't know what it is, but at least let's start listening to people.
Yes, that's exactly what I was going to say. Like, the very least we can do is ask how they are, how they're feeling, what they need, and then go from there. So thank you for doing that. And so I suppose we've talked a bit about why we do it and that sort of thing. But what I'm thinking is obviously I'm involved in focus groups and advisory boards and lots of things, and always will probably be. But if somebody's watching this or listening to this for the first time and are not aware of those things, I thought it might be worth you just explaining how you connect and what sort of activities you connect people to.
That's a great idea. Yeah. So it's amazing. There's a lot of different ways for people to share their voice in the ways that these companies and organizations are looking to. You mentioned a focus group. In the old days, focus group meant everybody drive to this facility and sit around the table. And that happens now and then. But even before COVID, with rare diseases, I mean, you're not going to get 8 people all available at the same time. And are they able to travel? And parking is such a hassle, all these things. So often it's a virtual group. But so often it could be a group of folks, which is an interesting conversation, because you may think, well, I don't have a lot to say. Well, somebody says something and it triggers a thought in your mind. And that's, they love this. Well, if you run it, that you love to see that, things you wouldn't find out otherwise, because they're bouncing ideas off of each other. So often we'll see what we'll call like an individual interview, a Zoom type interview, because I really want to just find out, really drill down deep. And it's conversational though. It's kind of like this. It's like, it's not question, answer. It's talk and wiggle around the different topics that people get into. And so often we'll have a lot of that. And then you can imagine when it's a rare disease, there's not a lot of folks to begin with. So they might do 5 or 10 interviews. They might not be able to do some big study. And some people love different types of studies. And the people we work with, hey, don't do what you don't like to do. Some people love to talk, but they don't want to get online and do a survey. Some people are reverse. Mm-hmm. Some people, we found out, we did a survey among folks in the UK about participating in this kind of work. And what I thought was interesting was there was a substantial group that said, I'd really rather not be in a group.
Yeah.
I got
That's
called the shyness factor. So you don't want them not to have a voice. So if you're doing groups, you may also want to do some individual interviews because you don't want to exclude the folks that are not comfortable being in a group. So there's that kind of thing, and there are certainly are the surveys. Check a box. Fortunately, more and more often they give you some open end because have you ever tried to do a survey and then none of the answers match what you're trying?
yeah.
You're like, I'm not getting this is not allowing me. So more have an open end and people can type in. I love it when we've done our own ones. We'll say, why do you say that? And we'll get so much that people will write. And I always feel compelled to read it. I even have thousands of responses because they put it in. They deserve to have us read it. And those can be like a in-person or a Zoom type interview often is scheduled for an hour. And a survey, well, if you make it an hour, you're taxing people because it can get tedious. So usually a half hours, 20 minutes to half an hour is a better length of that. But we also have clients that say, can we go into people's homes? We love to talk to them, but you learn a lot by seeing what they're actually doing in their home and how they're treating or what else is going on. That's where they'll say, hey, they have to spend their time with the other children too, not just the one with the disease. So we'll have folks do that. All sorts of different things. What it all comes down to is just they want to hear honestly what you have to say. And I always say, if somebody asks a question you're not comfortable answering, you could be like a politician. You don't have to answer it. Nobody can. There's no reason you should be uncomfortable.
And that is that catering for everyone. And like you've already mentioned there are some different cultural norms. Like, yeah, absolutely. In the UK, trying to get men to do anything in a group that doesn't involve sport, nobody's talking about how they feel in a group or anything like that here. and that's something we're sort of trying to break that sort of stigma down. And so not only you got the cultural things, but you have got the personality types and everything else. Like, anyone who's done any of these, like myself, we've all seen it where you'll get the loud voice and then the quiet one, and trying to sort of level that playing field and measure them all the same is really difficult.
Yeah. We've heard a lot from you. Thank you. Let's let Joe in the corner here who hasn't said a word. We'd like to hear what he has to say.
Yes, there is an art to it. So like you say, it's good that there is different ways of doing it to get that information, because otherwise it can be a little bit shout the loudest. And I'm always conscious of that. I'm in a privileged position. I get to go to conferences. I get to speak to medical professionals, but it shouldn't be about what matters to Joel. It should be what matters to patients as a whole and the majority. And that's, so I think that's where the work you do is really important for capturing that across the board experience.
And the folks like you that are doing interviews and stuff, it's really a skill because and a learned art, if you will, because you want to be empathetic and you want to draw out it's not just a robot asking questions. So and what I love to hear that, because we deal with all sorts of different companies that have their own interviewers and stuff, but we really hear such marvelous feedback. People say we're so thoughtful, respectful, empathetic. They learned a lot. The patient will learn a lot there. So I love to hear that, because these are not amateurs. They're real people that have kind of learned their trade, and they make you feel comfortable too. So if you ever get involved in this and do it, if you're nervous, just say that. But they should be doing a wonderful job when you get on this of making you. And I'm sure when you do these, you make people comfortable that you're not being judged. It's like when you show people, say, an ad to get their feedback. We're not judging you. We're judging the ad.
Judging the output. This is the thing that's being created. So how do you tackle that issue in terms of, like, because I know on social media is something I'm often trying to raise that, I can share a story on social media and you're kind of always almost preaching to the choir, because the people that are following that stuff are already turned on. They're already wanting to engage and hear it. Is there anything you do, and if you don't, then that's absolutely fine, but is there anything you do in terms of like trying to reach those other corners, because you're always going to get the people that want to share and have done it lots of times like I have, but what could we do to try and help those people that maybe haven't shared their experience get involved?
You have to just do a lot of different things. You can't just rely. Like, if you wanted an opinion, you might not. Your first thing is, well, let's go to the patient advocacy group for that, and that's wonderful, and that may work well. But some people aren't joining that group, or we even recruited folks from a group, and we asked them about patient advocacy groups, and some of them didn't even know it existed. It's like, we recruited you at their event. I mean, don't assume people are all tuned into this. So some of the things we'll do is, like, not only go to an event like a walk or a conference or whatever it might be where but people, wonderful thing again, all these unplanned things that worked out well for us, what we call referral partners. people know other people.
Yeah.
People know other patients. They might know them in a support group. It might be family members. Say it's a genetic disease or something like that. And sometimes broader than that. I remember when we were first starting, and I was in Albuquerque, New Mexico, at a wonderful multiple sclerosis walk, and people were excited about it. But one woman came up and she says, "I get it." She goes, "I'm connected with people all over the country." She had like her own closed Facebook page where they were always discussing Emma. So she put out the word. So you get the, like I said, because in the old days, if you just did the in-person group, in the US, you get people in Chicago and New York, and in the UK, you probably do London and London. But, but what about the person in here in Montana? They have a voice that deserves to be heard, or anywhere in some remote in area of Wales or whatever it might be. And that's a wonderful thing now with technology. Well, COVID forced us to do that, right? Because they weren't in person. But now people are learning. We can have people anywhere, and they can come in on, just like we're doing here at a platform at the same time, and it works. And so it does get people in from all walks of life. Now, what I say, if somebody doesn't want to share at all, I don't know how you're going to get them to do that. But so many people have one little thing they want to do. Like I say, some people might be comfortable doing a survey, but not an interview, and some vice versa. So offer a variety of ways of doing it, and a variety of ways of finding people. Again, we have over like 5,000 now referral partners. And some are individuals that just know a lot of people. Some are social media mavens that get the word out. Others are very much tied into certain advocacy groups or support groups. Anything and everything, because you don't want to just get the voice of the educated, active folks. Great starting point. But what about everybody else?
And I love that. And I love that you're going to them awareness, fundraising kind of events, like you said, the walks and everything, because so often in this line of work with advocacy, I'll say like, "Oh, how did we get the message out?" And they'll say, "Oh, well, we talked about it at a conference." I was like, "Well, that's great. You talked about it to doctors. There was no patients there because no one can afford the £1,500 ticket to get in or whatever that looks like."
It was on page 10 of our newsletter. It's like, I don't know if anybody got there.
So true. Page 10 of our newsletter. Well, they had to be on your mailing list that nobody subscribed to. And so I think, I love that about getting boots on the ground. Like I say, I know COVID changed everything and we have to work harder and use technology to reach far-flung, corners. Yeah. But that getting in the spaces, because that's why we're here on YouTube. I'm completely uncomfortable on camera. This is not my thing. I didn't grow up dreaming of doing any of this. Yeah. But we recognized that there was a group of people that were just watching videos and stuff to feel seen and represented. So we thought, well, why can't we go there and try and connect? So I love that you're doing that, because we do have to try harder. It's not just about chucking some flyers out at a conference and hope that a doctor passes it down the chain to the person living. Yeah.
And you're sitting back waiting, and so don't assume.
So I love that. So thank you for what you do. And I suppose if anyone's watching this and or listening back to it and wants to get involved, I have shared the website on the in the chat, and I will do in the description for the show as well. But if anyone wants to get involved, what does that look like?
Yeah, so I encourage people to go to our website. We try to put all the information that we could think of on that, and you can see rarepatientvoice.com. And we're happy to answer. I love it when people have questions. You can reach out to us. There's various ways to get the email and all sorts of things to connect with questions. And if you're interested, you'll see all these buttons. Click here to connect, and you click. They start asking you, well, what language and what country are you in, and then what disease or subdisease. They'll get into some detail about. We don't try to ask a ton, because we're not doing. This isn't a survey for us. We want enough information that we invite people to the right thing. I want to know if you have hemophilia B. I don't want to invite you to a study for hemophilia A, because that's wasting your time, and it's annoying, and you'll go in there and you'll won't qualify and you'll be upset. So we want to have enough to do that. We ask people, for example, what drugs, treatments, and stuff they use, but to be that's more of a double check, because nobody knows how to spell the names of their drugs. And
I can barely pronounce mine.
Yeah, and it could change tomorrow, and nobody's going back in to fix.
That's so true.
But to us, it's a good thing, because what we have to, unfortunately, in this day and age, guess what? There's fraud. There's fraud in market research. There's people. Your listeners here will be like, there's people that don't have a disease that pretend they do, because they want to get paid to do research. Well, so we have to go through, and again, when we meet people in person, when we get them through referral partners, we're well known to have they're real people, but we do have to go through for people that sign up online, and don't take it personally. It's just we have to do it. So we'll look at the
I'm sure the
medication versus
community
the disease.
appreciates that check to make sure that the experience has been shared, a genuine one. So yeah,
Yeah,
thank you.
and when in doubt, we'll call people on the phone. You could tell pretty quickly talking to somebody, right?
Yeah,
But I encourage people to go on, click on that if you're interested. It'll ask you those questions. Again, we try not to ask too much, but we'll have it in there. We don't share it with anybody. We don't sell it. We don't market to you. The only time we contact you is when we have a study that might match what you said, and we do it by email because it's less intrusive. But you do have to check your emails.
yeah.
So it works out well. So please, folks, do that. And I mentioned compensation. I don't think, but in the it's the same. Well, every year we have to check the exchange rates. But in the U.S., it's 120 U.S. dollars per hour. In the U.K., it's 95 pounds sterling per hour. We like to be very generous to the folks. And you know what? I think there's a value there because with the clients, people pay more attention to what they paid for. And the clients have paid. They're like, let's listen to these people. We paid for them to do this. So don't be shy about taking it. So many people say, thank you so much. You made my holidays because I have a little bit more to spend. I mean, this is nothing to the client companies. This is a tiny portion. And we, from the very beginning, we said, physicians do study, they're paid for their time. Patients should be compensated too. Now, clinical trials, there's a lot of times they're not. That's a whole other issue.
Yeah,
legal,
that's a
et cetera.
different value.
We like to advocate that it'd be nice if they could compensate them because, as you pointed out, there's so many income opportunities that they're foregoing. So
yeah, but also like for me, it's part of, and it's something I've been sort of passionate about over a number of years. It's part of the solution because the minute we start putting a value on those people's expertise in their condition and their daily lives and what they're living with, it kind of is shifting the dial, isn't it, on that in terms of like the value of it. Because for some of these organisations, unfortunately, the financial thing is the thing they understand. So you start putting a price on it, then you can start having that conversation about, well, see, there is a value to this, the same as there's a value to medical professionals' training and experience as well.
Yeah, you're starting to talk their language, right? When you put a financial figure on it, and so. Hey, whatever it takes to get noticed.
Yeah, no, I think it's great. And just to clarify, I know we've sort of hinted at it a couple times, but yeah, you're way beyond the US now, aren't you?
Oh yeah, I love when you said about half of your audience is US and UK. Those are our two biggest countries. Okay. Because US, we started in the US and we do a lot, but we've spread into the EU, and I know the UK is not whatever.
Yeah, it's complicated. We won't go there.
But the UK, because we have the stuff in various languages, in German and Spanish. But the US and UK are by far our largest communities, and so I welcome those. And again, wherever you may live, but especially those, we love you. We're always getting requests for opportunities for you to take part and share your voice.
Brilliant. This has been an absolute joy, Wes. I feel like we have a lot of shared views on this sort of thing and a lot of crossovers in terms of what work. Like purely coincidental, I didn't know that was going to be the case going into this. So it's been an absolute joy, and time has flown by. I'm conscious that you're giving up your Sunday afternoon to be with us. Is there just you've had the space? I know we mentioned a website and how people can get involved. Is there anything else you want to plug, social media or anything else you want to use the time for to talk about?
Well, that's a good point. We have a team that does a wonderful job on several social media ones, and some of them I never remember to go to Instagram or TikTok, whatever, but we have stuff there. But Facebook, we have a large following on Facebook. So I guess you just search for Rare Patient Voice on Facebook and you'll see, and they're always posting, hey, certain studies where we're looking for more people, and then inspirational messages, things like that. And then on kind of the business side, if you will, one of the ways I like to reach out to clients is LinkedIn. And we have a company page, but my own page. You can go to, I don't know what it is, Wes Michael. I think if you search for me, you'll find me pretty easily. And I just posted something the other day about doctors using AI, and AI did better than the doctors did. Wow. And I'm not saying that, but it's just like people use every tool you have. Don't assume, anyway. Yeah. So I like to post things we find out about conditions and diseases and things like that.
Yeah, no, that's brilliant. Thank you so much. I do hope you'll join us again some point in the future. Maybe if you've got a new launch or project or
Oh, that
something
would
you
be
want to
great.
share with
That
us,
would be
then
great.
yeah,
Yeah.
please do check back with us, and keep doing wonderful things. And yeah, I wish you all the very best. And
Thanks,
I'm so
Joel.
glad you did find the time to get this going
Yeah,
eventually.
I had a wonderful time this afternoon for me, this evening for you.
Yeah, brilliant. Well, enjoy the rest of your day, Wes. Thank you so much. I'll let you go now, and speak soon.
All right, thanks, Joel.
Thank you. Bye bye.